The next speaker is Professor Sara Kirk.
Thanks, everyone. It's really great to be here and have the opportunity to chat with you today. I'm just going to pull my slides up and then we'll get going. Okay. There we are. So I'll just give my disclosures as well. So as Denise mentioned, authors of the chapters and participants in these guidelines receive no payment. I do have funding for my own personal research at Dalhousie from the Canadian Institutes for Health Research, the Public Health Agency of Canada, and from the Dalhousie Medical Research Foundation. And I have no conflicts to declare either. So as you've just heard, these new CPGs, the new guidelines, are a major step forward in how obesity is managed in Canada. And I'm especially proud to have been the lead author on the chapter on weight bias, reducing weight bias, obesity stigma and discrimination, because it's the first time such a chapter has been included in guidelines of this type. So this chapter really is rooted, in my mind, in evidence and empathy. And I want to begin also by reiterating what Denise just talked about, that a major shift in the new guidelines is in the way that we use the term obesity to mean a progressive relapsing chronic disease where abnormal or excessive body fat or adiposity impairs health. What this means is that when we use the term obesity, we're not necessarily referring to weight or size. And we recognize that obesity is a stigmatized term. And that these guidelines use that term because this is the medical term for the disease that we're addressing with the guidelines, and because it is the term used in a lot of the research that underpins the guidelines. But we are using it specifically in these guidelines to mean the excess adiposity that impairs health. Of course, it's going to take time for this new definition to become understood and appropriately used. And so it should also be noted that while these guidelines are based on that best available evidence, much of the science available is also based on BMI and on weight measures. So we're advocating for a move away from weight and BMI as measures of obesity. But again, this will take time to translate into that clinical practice and also into research. And it's up to all of us really to create that shift, and why this chapter was included in these guidelines. So for this webinar, I'm going to define, first of all, what we mean by the terms weight bias, obesity stigma, and discrimination, and then talk about why these are important issues to address, given their prevalence and impact. And then I'm going to go over the recommendations in our chapter, because there's actually only a few recommendations, because again, as Denise mentioned, there's good evidence that weight bias, obesity stigma and discrimination are having an impact, but it's not always the best available evidence. So there's a lot of qualitative research that we had to look at to derive our recommendations. Okay, so let's get started. I want to get everybody on the same page with what we mean by the term weight bias. And this is the negative weight-related attitudes, beliefs, and assumptions and judgments in society that are held about people living in large bodies. It can be subdivided into these three categories of explicit weight bias, implicit weight bias, and internalized weight bias or self-directed bias. And explicit weight bias really refers to those overtly negative attitudes towards people with obesity that people may hold, whereas the implicit weight bias is those more unconscious negative attitudes towards people in larger bodies. The internalized weight bias or self-directed bias is the extent to which individuals living with obesity actually endorse those negative weight biased beliefs about themselves. And that's something that is actually relatively new in the literature as well, in terms of how that operationalizes and impacts how people engage with the health system as they are looking for support. And weight bias ultimately leads to stigma, which in turn can result in exclusion, marginalization, and the development of inequities. So as previously noted, weight or obesity stigma really doesn't represent that manifestation of weight bias through those harmful social stereotypes that are associated with people living with obesity. And then weight discrimination is the unjust treatment of individuals because of their weight. Moving on to the prevalence. Now, we know that weight bias and discrimination is rampant in our societies. It's present in our schools, it's in our workplaces, it's in health systems, and it's also widely represented in the media. And so we know that this is a problem. And here are some examples from the Rudd Center for Food Policy and Obesity in the US, which has perhaps doing the most research in this area currently. So elementary school children with obesity faces 63% higher chance of being bullied. 54% of adults with obesity report being stigmatized by their co-workers. 64% of adults with obesity report experiencing weight bias from a healthcare professional. And 72% of images and 77% of videos stigmatize people with obesity, according to recent studies. So we know that this is a problem, and we know that it's something that we need to do something about. The question then becomes, what is it that we need to do? And the impact of weight bias and stigma, really, they have far-reaching consequences for individuals. And at the center of this is the health and social inequalities that people with obesity are often experience. Things like poor educational or career outcomes, access to housing. And this also then leads to these the four outer rings here around the psychological health, social outcomes, healthcare delivery, and ultimately in increased morbidity and mortality. And there are physiological mechanisms that may contribute to this increased risk of things to people's physical and mental health. Things like chronic stress, which can increase cortisol levels, and oxidative stress independent of adiposity level, and that also increase the risk of obesity and diabetes. So these can then increase the risk of mortality. And one longitudinal study has suggested that perceiving weight discrimination is associated with a 60% increase in mortality risk. Eating disturbances, depression, anxiety, and body image dissatisfaction can also impact psychological health. And there's strong evidence that weight bias in healthcare settings can reduce the quality of care for patients living with obesity. And this is something that I've done some work over in Canada. Moving on then to the other thing, I think what those issues really kind of highlight is that weight stigma is actually a determinant of health that has individual health consequences as well as public health consequences. So when we think about the individual health consequences that people experience, there's things around unhealthy eating and lower physical activity, the psychosocial disorders that many people experience, the stress-induced pathophysiology that I just mentioned, and then the substandard healthcare and decreased healthcare utilization. For many people, actually going to the health system for support is a very stressful situation, and there is evidence of avoidance of healthcare because of those the stigmatizing treatment that they may receive in that system. In terms of the public health consequences, then we really have seen in many environments, and I would actually suggest the most recent campaign in the UK really does disregard the societal and environmental contributors to obesity, really framing the problem as being one of an individual. And that's problematic because we know that the environment is unhealthy. It's actually undermining health behaviours. And the more we focus on individual behaviours, the harder it is for people to recognise those societal environmental contributors that are impacting their health and well-being. And that then leads to these impaired obesity prevention efforts. If we're not focusing our attention on those big picture things that are causing challenges for people, then we're not going to actually see any change. And so it's really important to sort of recognize that this is not an issue of the individual. There are consequences to the individual, but we have to recognize those broader societal factors as well. And what this also increases is health disparities. So people living with obesity receive inadequate treatment in the health system, and that increases their health disparities and also their social inequalities. So these are all the things that then lead to this challenge with morbidity and mortality. So that leads me on to our recommendations. And as I mentioned, we have 4 recommendations within our chapter that I hope will be of interest to the audience today. So first of all, that healthcare providers should assess their own attitudes and beliefs regarding obesity and consider how their attitudes and beliefs may actually influence care delivery. Because we know that our attitudes do influence our behaviour, we understand that we need to know what's happening, how we're thinking about obesity as a health issue. We see it a lot in the research evidence around how people living with obesity may go to their healthcare provider and not have their concerns taken seriously, maybe dismissed, or even in some cases go about something completely unrelated, and then the issue gets switched around to their weight when that isn't actually the presenting problem. And one of the things that we all can do as healthcare providers is assess our own attitudes through self-assessment tools like the implicit association test, which is actually runs out of Harvard. There's a whole multitude of tests that can be used from within that platform. So something to definitely try and sometimes we even have to understand that we may hold negative attitudes, but how that influences our behavior is what we really need to be thinking about, and challenging our own biases in how we do our business with people. Some of the things you can think about to check your own attitude, as well as to think about whether you assume a person's health characteristics or behaviors and abilities are based on their body size, weight or shape. And thinking about how people actually come in different sizes and shapes. Body size, weight and shape are not directly associated with a person's health, their work ethic, their willpower, intelligence or skills. And if you think, do you think that everyone with a larger body size or a higher body BMI has obesity and needs to lose weight? Again, this comes to where the new definition that we're including in our guidelines around treating obesity as a chronic disease, where abnormal or excess body fat impairs health. BMI is not an indicator of body size. BMI is an indicator of body size, but it's not an indicator of health. Denise mentioned the Edmonton Obesity Staging System, or EOS, and again, really encourage you to have a look at that as a way to actually help to better address the way that we actually engage people in supporting them. So not everyone with a large body size or high BMI has obesity. And think about, do you believe people with obesity are personally responsible for their condition? Again, something we do hear a lot. It's often prevalent in the media, that kind of narrative. And many people think obesity can be controlled just by simply eating healthier and being more active. But there are many more factors that contribute to obesity that Sean is going to move on and talk about shortly. And many of these factors are actually beyond an individual's control. Our second recommendation is that healthcare providers should recognise that internalized weight bias, that's the weight bias that people might direct to themselves, in people with obesity may affect their behavioural and health outcomes. And just again, the evidence that underpins this is that this internalized stigma occurs when a person is aware that they have a stigmatized identity, and they apply those negative social stereotypes to themselves. So those sort of things like believing themselves to be lazy, awkward, sloppy, non-compliant, unintelligent, unsuccessful, or lacking in the self-discipline and self-control that's necessary to manage their weight. When people have weight bias internalization and self-stigma, then they're applying those negative weight bias stereotypes to themselves and engaging in self-blame for their weight status. So that's the sort of internal dialogue that people will have. I'm less attractive than most other people because of my weight. I feel anxious about being overweight because of what people might think of me. So really understanding that and how that is impacting when that person comes to see you in a clinic or interacts with you in some way in the health system, that's a barrier that will make it harder to build that therapeutic relationship, but we really have to be aware of it and work to overcome it. And I feel always that, I shouldn't even have to be saying this, but shaming is ineffective. Individuals with higher internalized weight bias report less weight loss, lower physical activity levels, higher calorie intake, greater disordered eating behaviors, and actually shameful public health messaging or shameful messaging within a clinic environment could inadvertently make the problem worse and harm those most in need of help. So when we're talking about, again, I say this, and I'm, it's hard for me to actually even, acknowledge myself that this still happens. We see this, I hear this, we see it even in the media reports around the guidelines. There was still that shaming narrative, shaming images coming out, and it's something that I, really, if nothing else happens with this chapter, that we start to make a change there. The third recommendation is that healthcare providers should avoid using judgmental words or images and practices when they're working with patients with obesity. So thinking about some of the words we, and again, I think we all struggle with this as well. Like, what are the words that we should be using? How should we be talking about people? The first thing I would say is ask the patient themselves, ask people themselves, and the work that's been done, again, this is work from Rebecca Poole in the US, there are certain words that people find to be less desirable or more stigmatizing or blaming and less motivating, and those are on the screen now. So, really being careful to actually, ask people what term is what they prefer, and just being very careful, again, decoupling weight from health is part of that. So patients who experience weight bias in healthcare settings may delay or forego essential preventive care, things like breast or cervical and colorectal cancer screening, for fear of receiving that disrespectful treatment and negative attitudes from providers. And we know that the environment plays a critical role in influencing the opportunities, the benefits, and the burdens of individuals within a society. So we need to also think about how our environment is set up. So ensuring that our clinical environment is accessible, that it's safe, and it's respectful to patients regardless of their body weight or size. On the screen now we have some of the work actually that's come from Mary Forhan, who Denise mentioned earlier as well. Mary is an occupational therapist by training, and has done a lot of work around, again, looking at how to make our clinic environments be more respectful. And we have an assessment there on the screen. Again, these are all available through the Clinical Practice Guidelines website. Our final recommendation is that healthcare providers avoid making assumptions that an ailment or a complaint that a patient presents with is related to their body weight. And some of the work that I've done on this is, again, that people, when they go to see their healthcare provider, are often not listened to. They might talk about the problems that they're facing outside of that, but it all gets brought down to their, just you need to eat right and exercise and you'll lose weight. It's as simple as that. It's a simple thing. And we know that it is not a simple thing, and it's something that is very complex, and we have to recognize that in the way that we practice. On the right, another issue that we see is how weight bias negatively affects patients' engagement in primary healthcare through their perceived barriers to healthcare utilisation, their expectations of differential healthcare treatment, their low trust and poor communication, and then avoidance or delay of health services, and things like doctor shopping. So actually trying to find a healthcare provider who can actually help them more, or be less judgmental with them. So to conclude, weight bias, obesity, stigma, and discrimination do cause harm to health and to social well-being, and they impact healthcare delivery. It's really critical that anybody working in this field, assesses our own biases, the explicit, implicit, and internalized biases that we have. Think about our language. Using person-first language is really the way to go. Changing that narrative that obesity is a lifestyle or behavior choice, really pushing back on that and trying to get people to recognize those broader factors in our society that are undermining our behaviors, and particularly undermining our ability to choose healthier behaviors. And understanding the perspectives of patients living with obesity is vital to achieving that patient-centered care in primary care and in terms of improving health outcomes. And finally, to think about those physical environments and making sure that they're accessible, safe, and respectful to all patients, regardless of their weight and size. As Denise mentioned, you can access the guidelines through the link on this slide here. And again, I'll come back to the point I made at the beginning. We really tried with this guideline and this particular chapter to consider, again, the evidence and do it in a way that also generates empathy. And thank you, and I'll pass now on to Sean.